Okay, hi everyone. We're slowly gonna get started because I have roughly 2 minutes I need for the introduction. So I figure by then people will be slowly finding their spots. So it's my distinct pleasure to introduce today's UCLA CTSI lecturer invited on behalf of the cardiovascular theme, Dr. Roger Hajjar. Dr. Hajjar serves as the inaugural director of the Gene and Cell Therapy Institute at Mass General Brigham, overseeing a large group of investigators focused on early to late stage gene and cell therapies for a variety of diseases. He received his bachelor's degree in biomedical engineering from Johns Hopkins and his MD from Harvard, where he pursued training in the joint Harvard MIT Division of Health Sciences and Technology. Dr. Hajjar completed training in internal medicine, cardiology, and research at MGH, as well as advanced heart disease at the Brigham. He became faculty at Harvard in 1997 and directed the Cardiovascular Laboratory of Integrative Physiology and Imaging. He was then recruited by Mount Sinai in 2007 as the founding director of the Cardiovascular Research Center and the Arthur and Janet Ross Professor of Medicine, a position he held for a decade. Subsequently, Dr. Hajjar was involved in the creation of multiple gene therapy companies that emanated from his academic research and was the head of R&D at Ring Therapeutics prior to being recruited back to Harvard in his current position in 2022. Dr. Hajjar is an internationally renowned scientific leader in the field of cardiac gene therapy. His laboratory validated a number of cardiac targets that led to the initiation and completion, under his guidance, of first-in-human gene therapy trials in patients with heart failure. In particular, his group has taken the concept of targeting calcium cycling in heart failure from bench to bedside with first-in-human clinical trials of AAV vectors carrying the SERCA2a gene in patients with various forms of heart failure. I'd like to highlight the CUPID trial, which stands for Calcium Upregulation by Percutaneous Administration of Gene Therapy in Cardiac Disease, which was really pivotal in this field by demonstrating the feasibility and also the safety of gene therapy in patients with heart failure. In addition, his laboratory has recently initiated an international phase 2 trial using a novel cardiotropic AAV vector to deliver a constitutively active protein phosphatase 1 inhibitor. He has authored over 500 publications and has received numerous awards for his achievements in cardiac gene therapy, including the Distinguished Alumnus Award from Johns Hopkins, the Doris Duke Clinical Scientist Award, and the Distinguished Achievement Award, as well as the Thomas Smith Award by the American Heart Association. Dr. Hajjar has given well over 500 invited lectures and trained over 60 scientists, the majority of whom have pursued independent academic careers. Please join me in welcoming Dr. Hajjar, whose lecture is entitled Cardiac Gene Therapy.
Thank you very much, Renee. This is a real pleasure to be back at UCLA. I've had the sort of privilege and pleasure to be here a number of times over the last 2 decades, and I see the growth continuing. So from the work that I will describe today, I will give you sort of a general view of cardiac gene therapy as it is today. It's really exciting times for it. And I'll try to give you sort of what's coming in the future, or at least what we think is coming in the future from a gene therapy perspective, and how academic medical centers like UCLA and us can navigate through that. So the gene and cell therapy landscape has really expanded across modalities and therapeutic areas. Here's just a snapshot from a few months ago of the number of clinical trials that are ongoing in gene therapy, in cell therapy, and RNA therapy. Clearly, this is sort of what you see in general for many different modalities, but in gene and cell therapy, many phase ones get started, and then fewer and fewer phase 2, and especially phase 3. The spaces where we see a lot of gene and cell therapy occurring are rare diseases, oncology, and neurology. So those are really the big areas where we've seen gene therapy work. And of course, with RNA therapy, vaccines have emerged as with mRNA therapy as sort of the target for this type of modality. Now, of course, there's work being done with RNAi and shRNA in a variety of diseases that have already are being used clinically. Now, the recent successes basically has been building momentum for more approvals and innovations, and I think we see sort of a clear direction of enhanced number of approvals, and some of them that are notable here include AV9 using minidystrophin for DMD, and for sickle cell disease, the first gene editing therapy that was put forward by Vertex and CRISPR Therapeutics. So these are really big sort of inflection points that we've seen in approvals, and these are continuing now as we see more and more approvals, especially for rare diseases. Now, in the gene therapy pipeline, as I said, oncology, neurology really dominate along with rare diseases. As you can see here, very few cardiovascular therapies are being evaluated. And that's not because there's less interest, but I feel that's the more focus has been on rare diseases, as reimbursement for rare diseases has been quite steady, and there are a lot of forces that at play when you look at the clinical development programs in the non-oncology, non-rare disease space. So clearly for us as cardiologists, and especially in the heart failure field, we continue to be dealt with a very big unmet need. And despite pharmacological and device therapies, if you look at the survivals in patients with heart failure and compare them to survival in certain cancers, both for males on the left side and females on the right, you clearly see that the heart failure survival continues to be quite dismal, despite all of our device therapies and pharmacotherapies that we have. And for males, it's as bad as colorectal CA and prostate CA. And for women, it's as bad as ovarian CA, one of the sort of deadly cancers that we have. So clearly, we still have a big unmet need, and we need to sort of deploy different methodologies. And from a simplistic point of view, you can think of what happens in heart failure as an injury that comes in to a normal myocardium, and that injury can be coronary disease with ischemia, inflammation, such as myocarditis, or genetic predisposition or a causative genetic mutation that basically induces either mild dysfunction or straight into an advanced heart failure phenotype. And there you have the opportunity to sort of target different areas, whether it's an extracellular matrix with fibrosis or the cardiac myocytes, or replacing the dead cardiac cells that occur in a variety of these etiologies. So very early on, we were very much focused on the cardiac myocyte physiology and how can we sort of rescue the function. To us, the sort of the promise trials back in the 80s and 90s was trying to revive the cardiac cell function. The negative data seemed to be due to sort of a non-targeted approach, and we really wanted to sort of focus on how can you revive the cardiac cells who, regardless of the etiology, end up being dysfunctional. So when we think about the cardiac cells, I mean, excitation, contraction, coupling is really the focus of our understanding. So membrane depolarization induces the entry of a small amount of calcium through the L-type calcium channel, and that calcium, in turn, coming out from the ryanodine receptor in the sarcoplasmic reticulum, induce the contraction based on the interaction of the myofilaments here with the myosin heads. And then during relaxation, calcium is taken back up into the sarcoplasmic reticulum, and some of it through the sodium calcium exchanger extruded outside the cells. So for many years, our lab was interested in the fact that in heart failure, regardless of the etiology, whether it's ischemic, non-ischemic, whether it's even hypertrophic cardiomyopathy, and also a large number of hereditary cardiomyopathy, as I'll show you, the intracellular calcium handling was abnormal, and many of that was due to abnormal in ryanodine receptor function and also in the uptake of calcium by the SR calcium ATPase pump. And SERCA2A played a big role in the calcium handling because it was responsible for the uptake during relaxation, so loading up the SR and reducing diastolic calcium. And it was also responsible for the release of calcium because as the SR was loaded with calcium, it basically released a proportionate amount for the contraction to occur. Now, SERCA2A is highly regulated inside the SR. Phospholamban, which is shown here at PLN, is a very important protein that inhibits SERCA2A in its unphosphorylated form. And when it gets phosphorylated, that inhibition goes away, allowing SERCA activity to go up. So we've been able to target multiple areas in this scheme, including the phosphorylation of phospholamban, because in heart failure, not only do we have a decrease in SERCA2A function and amount, but we also have a hypophosphorylation of phospholamban, meaning more inhibition, and that's regulated by protein phosphatase 1. So targeting protein phosphatase 1 was another scheme that we had for our therapeutics. So early on in my career, when we started focusing on SERCA2A, we tried pharmacological maneuvers to enhance its activity, but we always had side effects from the small molecules that we were generating. And finally, we had performed many of these studies using genetic manipulation, mainly at that time with adenovirus. And we felt that with the coming of age of AAV, that maybe a gene therapy approach could be performed. And when you think about gene therapy for heart failure or for any cardiovascular diseases, you have to sort of think of the choice of vectors, the modes of delivery, the immune response, and obviously setting up the right clinical trials. So vectors for cardiac applications in the clinic have really varied across the board. The adenovirus has been sort of the workhorse of gene therapy across many organs. It's double-stranded DNA. It's very promiscuous and gives you a very strong response, but unfortunately, it also induces a strong immune response that basically causes inflammation, and the vector and the transgene are wiped out very quickly. Lentiviruses have been very good, and we use them in CAR-T all the time for hematopoietic cells, but unfortunately for cardiac cells, it's been less efficacious and requires a large amount, and obviously with the question of whether it integrates in the right area has always been one thing that we sort of, with the low efficacy, didn't really pursue too much. Plasmid DNA have been used, even the modified RNA used for vaccines have been used, but really the game changer for us in cardiovascular gene therapy has been the onset of AAV. So AAV vectors are helper-dependent parvoviruses. Uh, Clinically, they don't cause any pathology. They cannot replicate by themselves, and they require the machinery of an adenovirus. That's why it's an adeno-associated virus. It's a single-stranded DNA that becomes double-stranded in the nucleus, and then message is formed. It results in long-term expression, especially in tissues that are non-replicating. So for the heart, it's a real, if you need long-term expression, it's a vector to use. And there are different serotypes of AAV vectors from 1 now to RH10 and 11, where you can see that the different serotypes have different tropism for different organs. So a lot of the liver targeting has been with AV8, a lot of the cardiac deliveries with AV9, and so on. So this has been really the playbook of the initial trials, not just in the heart, but in different organs. And you can see the size of the AAV, which is important for us as cardiologists as we try to think about how to deliver AAV more locally. Now, beyond the naturally occurring AAVs, you can actually have more capsids made by taking the known AAV vectors, the genome of the known capsid, breaking them down and allowing them to reconstitute, forming mosaics. And then you can test them for specific type of characteristics you want. You want it to be more liver targeted, or you want it to be detargeting the liver. You want it more cardiac tropic. So you can do these types of experiments we call directed evolution, so that you're able to amplify the capsid that you really want to have the characteristics that you want. So that's really has expanded tremendously the number of capsids with AAV. So what we have looked at from early on was that we weren't sure that just giving intravenous delivery, despite the high tropism that certain vectors have, that we wanted to get as high of an expression as possible across the myocardium. So we basically looked at different methods, direct injection into the myocardium, that causes expression at the sites of delivery. We have the stop flow, where you can basically deliver retrograde while blocking antegrade. You can also deliver antegrade while blocking retrograde. So different methods for delivering. One of the best methods is using a bypass, obviously extremely invasive. This is an AV vector with a near-infrared fluorescent protein that you can see in this pig heart going in and infecting most of the myocardium, but clearly very invasive. We just recently also added to this delivery methods by using Impella, so mechanical support on top of coronary delivery, and we just published that. But I'm not going to get into that, but the method that we used that seemed to be the simplest and really can get us the buy-in from cath labs was an antegrade injection. So a downstream from the coronary artery without blocking anything, just a slow infusion. And with that, we added a number of factors that we knew could enhance uptake. So increased dwell time. So instead of directly injecting, we have a slow infusion over 10, 15 minutes. We add cyclic GMP modulators, in this case, nitroglycerin, which is safe to give in patients with heart failure, and increases coronary flow. We can't obviously enhance perfusion pressure, because that obviously gives us issues with dissection of coronaries. And so these are sort of the parameters we can play with, and that's what we try to do in our work. Now, AV vectors in general have a nice sort of immune response. They're relatively immune quiet. However, because we are using higher and higher doses of AV vector, what happens is that these vectors are taken up by MHC class 1 cells, and then at these very high doses are exposed to the circulation, and that's when a T cell response occurred. And we can measure this T cell response with an ELISpot assay towards the capsid that we're using. And the first sign of this is liver function test abnormalities, where you see ALT and AST go up. And I'll get into that in a little bit, but this is the potential for T cell response that you can get from AAV. So early on, we started with this construct. Interesting, when we started AV7, 8, 9, RH10, were not even discovered yet, so we had only to deal with AV1. This was back in 2007, and we constructed this cassette with circuit 2A and a CMV promoter, and we delivered it through our coronary. And this was kind of the method that we had, where patients would, it was an outpatient procedure. And nowadays we do it mainly in the arm, but back then we did femoral approach, where we inject down, this is sort of the ideal situation, a non-ischemic cardiomyopathy patients with no blockages, where we're injecting in the left main 2/3 of our 60 ml that we inject, and then 1/3 in the right coronary artery. We regulate this using injection systems so that we are exactly injecting for 10 minutes, because that's really helps with the uptake. And by doing that, we're able to really get the maximum amount of uptake. Now, we completed the CUPID trial in 2015, 16, and unfortunately, in that first trial of 250 patients, and that was one of the largest gene therapy trials at that time. I think it still is one of the largest gene therapy trials. We did not see any improvements in these patients with class 3, class 4 heart failure. And one of the reasons was that the uptake using the dose that was allowed back then by the FDA, which was very, very low, was not high enough. And then in the CUPID trial, we saw a very minimal uptake, so less than 1% of the cardiac cells. And we went to the FDA and explained that to them, but at that time, they wouldn't budge on the low dose. And we knew that from our animal studies across multiple species, there was a very clear, steep dose response. And we really needed to be on the other side of the dose response and not at the low end where we were with the CUPID trials. So we expanded our trials from that initial failure, where we are now in HFrEF, heart failure with preserved ejection fraction, and Duchenne cardiomyopathy. So for the HFrEF program, we increased our doses, and we started with, again, a very sick population, EF less than 35%, class 3, class 4 patients. And there's a neutralizing antibodies against AV1, where they're excluded if they're 1 to 5 or more. That's just to make sure that we don't neutralize the vectors that we're sending in. And this is the data, early data from our first few patients, and we just completed this trial, and we have more data coming in. But you can see the green is sort of improvement, and red is worsening. And as heart failure cardiologists, we like to see sort of obviously a concordance of improvements. We don't expect every parameter to improve, but as long as you have this concordance, we feel much better about it. And as we increase the dose, we see more and more of that. So this is completed, and now we are in the phase 2 trial, which is an international trial, bringing in the high dose versus placebo in multiple countries, both in Europe, US, and Asia. So first time we're doing a cardiac gene therapy in Asia using this protocol. Now, with heart failure and preserved ejection fraction, one of the areas we alluded to was engineered tissues. So we create, I mean, as you probably know, there are a few models of HFpEF, none of them are ideal. And we decided to create one using engineered tissue. And we did that with just simple ventricular cardiac tissue strips and the more complex cardiac organelle. And these had the sort of characteristics of HFpEF with increased stiffness, PV loops that looked okay in terms of contraction, but the relaxation was severely impaired is what the characteristics that we have in HFpEF. We knew that CIRCA was downregulated in HFpEF in the models that we had created, and it was true here. And when we delivered AV CIRCA, we were able to reduce the contraction time and reduce the relaxation time, which is what really we wanted to do. And interestingly, because the FDA has really changed its rules for acceptance of pharmacological studies, and this is based on the Modernization Act 2.0 and now 3.0, you are able to, or you're allowed to use engineered tissues or cells in lieu of animal models. And in fact, we got our IND based on this pharmacological study, and we got a fast track designation, again, based on these engineered tissue. And our trial looked at how our gene delivery affects the wedge pressure. So we were very focused on getting HFpEF patients who had elevated wedge pressure, and we wanted to see whether our gene therapy has any effect in these patients. And this is sort of one of our patients at Duke, where we had an EF more than 50%, elevated wedge pressure, and we basically exercise them during the cath lab. The catheter is in the wedge position. And these are the first data that we saw where we're able to really see a decrease in the wedge pressure at 6 months post gene transfer, along with signals in 6-minute walk test, NT-proBNP, and New York Heart Association. It was really our first evidence where we can have a disease modification based on our therapy. Now, for Duchenne cardiomyopathy, again, Duchenne patients have clearly many options early on, including the Sarepta gene therapy product. But as they get older, especially in their third decade of life, they invariably develop cardiomyopathy, and that cardiomyopathy is pretty much resistant to the usual heart failure drugs that we have. So there's a big unmet need that we have, and we really focus on these patients who are older. Many of them are already wheelchair bound, but have severe forms of heart failure. And this was based on a lot of work that our lab and others, including here from Dong Xuan lab in Kansas, where we delivered 1 dose of AV CIRCA in these DMD mice and came back 2 years later, and were able to rescue the contractile dysfunction, as you can see from the PV loops here, and also decrease in fibrosis and reversal of even some skeletal muscle dysfunction. We then worked with Christian Kupat at the Technical University in Munich, where he had generated DMD pig models. And this time we delivered using our GMP grade AV CIRCA. And here again, we're able to reverse the contractile dysfunction, which develops very early on in these pigs, reversal of the fibrosis, some markers of inflammation, and restitution of microvascularization. One thing that I just wasn't very much aware of is that the arrhythmias that do occur in patients with DMD, and a lot of people feel that this is a mode of exit. And again, this is just showing that untreated DMD pigs have very low amplitude areas that cover the ventricles, and this is reversed using AV CIRCA. So the current trial is ongoing. We've dosed our first 3 patients, and we're starting our cohort 2. So we're quite excited to see the results in the next few months in this patient population. So as I mentioned earlier, we have expanded the capsids that we have with AAV into sort of re-engineered capsid with high cardiac tropism, the detargeting of the liver, and can they be resistant to antecedent neutralizing antibody that exists in many of us for specific serotypes. And that's exactly what we did for a specific indication. And this time the target is protein phosphatase 1. As I mentioned, protein phosphatase 1 is elevated in heart failure and causes phospholamban to be dephosphorylated and inhibit SERCA. And we produced an inhibitor of protein phosphatase 1 that's endogenous. And the idea is that you inhibit PP1, you decrease or you increase the phosphorylation of phospholamban and thereby increase SERCA activity. And our collaborator, Jude Samolsky and Arvind Asokan at UNC at that time generated a specific AV vector called 2I8. So it's a mosaic between 2 and 8 that detargets the liver. That was its main function because that's where the inflammation occurs, but at the same time had high muscle tropism. And when we use this clinically, so in a patient with heart failure and delivered it by intracoronary, with a relatively low dose, we're able to see that 15 months later, that patient had pretty much 100% of the myocardium infected with the AV vector. So this really showed us that you can get very high levels of vector uptake, and this was validated by RNA-scope for the I1C gene. And this is our phase 1 trial that we did, completed about a year ago, 2 different doses of AV2I1C, similar setup in terms of the different functions that we look at for heart failure, EF, quality of life, VO2 max, 6-minute walk test. And again, you want to see that concordance of improvements. And in this case, interestingly, the lower dose had a higher, sort of a better outcome in terms of the outcomes that we had put in. And